for those of you that have joined and you've just submitted your Oriel application, congratulations. That's one big headache out of the way. And I know this is a really anxious time, but it's also a really big relief because, that type of admin is gone out of your life now.
Yeah, and one less thing to think about.
Yeah, and it's not, no longer in your hands. You can sleep tight, I hope.
Focus your efforts on something else.
Yeah, and it's really good that you guys are here thinking about the next step now. And as always, feel free to ask any questions as we go through this. But I think we can get a start on, I guess.
Yeah, awesome. Have you got control of the slides, Aqua?
Yes.
Yeah. Okay. Hello, everyone. My name is Ollie. I'm joined tonight by Dr. Asif here, but we'll introduce ourselves more in a moment. Sorry, just as always, we have to preface these talks about the Specialised Foundation Programme by saying that all of the views expressed in this talk and the series overall are solely our own views. They do not reflect the views of the NHS, the trusts we work for, or any of the official bodies that we're involved with, or indeed the UKFPO, or anyone involved with the Specialised Foundation Programme itself. This is our interpretation of what's going on that you're hearing about.
It's separate, and we just wanted to give this to you guys, as a tip, as to help you guys, I think.
Yeah. So welcome. And this is the second session. They're the same time every week, 7:30 p.m. on a Thursday, for a minimum of 8 sessions, potentially more depending on demand, but we'll certainly be finishing out this series. So in terms of introductions, we'll just take a moment to introduce ourselves.
And just unfortunately, our close friend who is our third colleague, I think he's enjoying a much needed trip with his girlfriend, I think, in Spain. So apologies that he's not here. But
yeah, he's stuck at an airport somewhere.
Yeah, in Spain or something.
Yeah, unable. Pardon me. Unable to be here. But actually, importantly for this session, both Alex, who we were just were sending his apologies there, and Aqua, as she'll say in a moment, are working down as part of the London academic unit, which is kind of important for the purposes of this session. So my name's Ollie. I am an academic Foundation 2 doctor. I trained at Warwick doing the graduate entry programme. So I'm currently, for any of you that know Newcastle, I am based between the 2 big tertiary centres there, the Royal Victoria and the Freeman, our local big transplant surgical centre. Academically, I'm affiliated with Newcastle University, where I'm a training fellow within the medical school. In my first year, as when you do your F1, I did rotations in hepatobiliary and transplant surgery, an academic rotation, and then finished up on acute internal medicine. And then I've just started F2 this past August. I'm currently working as a neurology SHO with an academic block upcoming, and then finishing on psychiatry, so quite a cerebral second year. And then I'm interested primarily in neurosurgery and interventional neuroradiology.
Yeah. And then there's me. I went to med school at Leicester, and now I'm based in Surrey. And I'm associated with 3 different institutions because that's where I do most of my research. I'm mostly affiliated with UCL, but because of my SFP now, I'm part of University of Surrey, and alongside Ollie, I am doing research with Newcastle. So I'm currently on general surgery. I'm an academic FY1. Then I'll be moving on to stroke rehab, and then I'm on my emergency block. With my F2, I'll be starting on academic, and then oddly, I'm going to have another academic block of endocrinology, and then hopefully, depending on the last person agreeing with the swap, I hope to get onto urology. Because crucially, I want to be an academic urologist. I want to do either uro-oncology or andrology, aka I want to dedicate my whole life to prostates, penises, and testicles.
Someone's got to, haven't they? Right.
Yeah, exactly. Somebody has to.
So tonight's session, guys, is all about critical appraisal, which is it's a big, scary phrase that for many of us, I think coming up to the AFP and the SFP is kind of the first time that lots of us will hear about critical appraisal and think, oh, that sounds technical. What actually is critical appraisal? Well, there are lots of definitions, but I think perhaps the most useful one is it's a systematic process. That means it is a structured and formulaic process and thing that we do, and we'll talk more about that, of a piece or a body of research or evidence to judge its trustworthiness and overall its value within the body of existing evidence. And in short, to think about it very, very simply, how good is it as a piece of work, as a piece of research, and how much should we base our clinical decisions on it? Because we're taught from day one of medical school that we practice evidence-based medicine, and that's kind of the cornerstone of everything we do. But because of that, we're only as good as the evidence that we have. If we're doing evidence-based medicine with bad evidence, then we're doing bad medicine. So we need to be able to appraise critically the value of what we're looking at. So I'm going to take you through the first half of this presentation, talking about the basics of how to analyze a paper, the key questions that you need to ask, and then Aqua is going to take you through the more technical, perhaps important bits that you'll need for your interview, which is the next stage. So we're just going to go through it slowly, and forgive me because it's a lot of slides. We've split this into lots of subsections, but I think it's the easiest way to approach it. So it seems a fairly obvious thing to say, but you start with the title of your paper, because when you're reading anything, the title is the first thing you see. It's the key summary. You've got to get across the key bits of information. So what is the title? Obviously, you've got to be able to read it. That would be a good start. Now, is it purely descriptive of events? Because you can imagine, if you've ever read a paper, you could see, incidents of carotid artery aneurysms between 2000 and 2022, a systematic review. Like, that would be a good title for a paper, because it tells you literally exactly what was done. Yeah. However, many titles aren't like that, and you'll come across titles that have other things in them. They might have claims, they might have puns in them sometimes. Like, we've published a paper with a pun in it.
Yes, we have.
So
and its goal was to grab attention. Yeah,
exactly. Do the authors make any claims in their title? You know, you could imagine a title like Ramipril is superior to calcium channel blockers generally in managing hypertension, for example. That's a specific claim that's being made. And you would obviously have to read the abstract and the paper to work out what they've done, unlike the first example. Is it written in such a way as to attract attention, or has jargon? As we were just, sorry, Aqua, as we were just talking about, often they're designed in such a way to grab attention, but may not be fully descriptive. But coming on to the journal, this is the second important thing to ask now. A journal is like the setting in which academic articles and papers live. It's where they are published. So which journal has your article been published in? Have you ever heard of it before? There's an opportunity for bias to creep in. If I start throwing out names like the Lancet, like the New England Journal of Medicine, that sort of holy grail, high impact journal that everyone's heard of, and then you start to think about other journals like the Postgraduate Medical Journal. I don't know if any of you have ever heard of that. The point I'm trying to make is, it may be a journal with which you are familiar, it may be a journal that you've never heard of, but if you have pre-existing views about that journal, or that journal has a reputation, that can start to colour how you interpret an abstract. Is it broadly considered reputable? You know, journals like the Lancet, like New England Journal, are broadly considered reputable. If you get your Lancet paper, that's something that every author wants, or Nature, you know, these big journals. However, just because it's a reputable journal, it doesn't mean that all research published within it is good research. The example that you'll all have heard of is the Andrew Wakefield paper on was it some ileal hyperplasia or something, the paper that tried to link autism and gut disease, published in the Lancet, so don't take it as gospel.
No.
Does it have a high impact factor? Now, impact factor is one of the things that I would encourage you to go away and read about. It's kind of its own topic, not suitable for here, but those big journals, New England Journal, the Lancet, Nature, these journals all have very high impact. Yeah, JAMA, great example, have big impact factors.
But I think crucially, when it comes to London specifically as well, and other deaneries like London, Cambridge, Oxford, it's important for you to recognise how BMJ lays out their abstracts. How does Lancet lay out their abstracts? Like, whenever I see a New England abstract, I know that they always have like their funding at the very bottom of the conclusions, and they'll be like bracket funded by XYZ, whereas BMJ will have it in a different format. And usually when it comes to London, they'll copy and paste it and put it on they'll screen share, and they'll show it to you in such a way that you can't recognize it because of the formatting. But if you just know how it's laid out and some of the keywords, then you'll be able to be like, yes, it's from that study. Sorry, is that from that journal? So I would go home and go through how JAMA, BMJ, Lancet, New England, like how they, and Nature, how they are exactly. So you'll pick it up, and who knows, you might even get a paper that you've practiced with your mates.
Yeah, and they're good for writing your own papers as well. But like, that's how an abstract should be. The next one is setting, which is the context of your study, where it's taking place, where are the authors from, where are the patients from. So your study might be set in North America, like really commonly. It might be cities in the United Kingdom. Again, there's a difference, for example, between Newcastle and London in terms of its population, its demographics. So it's a really simple one, but what is the context? What are we looking at? And we'll talk later about how that might influence a paper. Authorship is a really kind of easy one to get to grips with because it's an easy concept to understand. An author is somebody who is listed on the authorship line of a paper, which is usually at the top. Who are the authors? How many are there? There's a huge difference between what me and Aqua by ourselves could write compared to what a team of 30 people could do if they're all working together. So if a paper's got one author on it compared to, hundreds of authors can be on papers now, it gives you an idea about the scope and scale. Who is the first author? That's one of the big questions because that's the person that's got their name attached to it, basically. This all rides on them. You could equally make an argument, I think, Aqua for senior author as well, like the person at the end. Because if you're sometimes getting into those high impact factor journals that everyone wants, having a big professor as the senior author on your paper might make
some weight
easier. Yeah.
And I would, like, for example, when it comes to authorship as well, if you see like a systematic review and there's one author, I'd be a bit, like, what? That's a bit, how can you properly do that? That doesn't sound like it's appropriate. And for example, if it's a big randomized control trial and it has, again, one author, it's like, that should raise your alarm bells. Like,
some steps have been skipped in that LCT.
And talking into like the ethical stuff as well, like when it comes to representation, if you see a study, obviously I'm not talking about old studies where, like, 1980s, 1970s, fine, but if it was a 2020 paper and you see that it's about women's health and it's all just men, for example, again, that is something that you could, if you felt ballsy on the day of your interview, you could raise it. Because then, did they have adequate PPI involvement? Like, those are just some conscientious points that you can raise.
Yeah, lots of these things are based on our perspectives as authors, and like Aqua said, women's health is a great one where, you know, as a heterosexual white man, if I was, for example, going to be doing any kind of reflexive or qualitative analysis on, I don't know, perspectives of female doctors in the NHS or something like that, if I'm doing an analysis that relies on my interpretation of something, that can be a real limitation because I wouldn't have that lived experience to know, you know, that's not to say my experience wouldn't have value, but it would
It's not true
alter,
yeah.
it would alter the claims that I might be able to make or what I am capable of recognizing when I'm doing that interpretation. And as well, think about other professionals. So not just doctors, not just surgeons, but you may have, you know, you could have nurses, midwives, dietitians, physiotherapists, occupational therapists, you know, art therapists, lots of different groups. Yeah. Now, language is a brief point because I think it's fair to say that anything you'll be asked to do as part of your SFP interview will be in English. It would be a strange curveball to present you with a non-English paper.
No, it's more in the sense that, like, in systematic reviews, if you see that they've only included English language, you know, language as a criteria, then that's subject to so much bias because there are so many good papers that could be written in Spanish, Russian, like all the other languages. And I think the bias specifically, if you can say this in your interview, they're going to be like, wow. But the specific bias is called Tower of Babel. I think that's how you pronounce the word. Yeah, and that's when only English language studies are included, and unfortunately, that has its own, you know, issues.
So, again, for those of you who don't know what that is, I think it's an old biblical story, or for any Hitchhiker's Guide to the Galaxy fans out there, the Babel fish or the Babel fish or whatever it's called, all references to the same thing, this idea of language. And that's what that second bullet point there is about. It, as Aqua says, a systematic review is a really good example. Or you could think about a randomized controlled trial where you need huge numbers of patients in order to make them work, especially for bold claims, especially where population health might be different. For example, if your patient group is in London, that might be very different to Beijing or Nairobi or any of these other places. Different determinants of health, and if you're only including certain populations and certain bodies of evidence, then that will affect your outcome. And this last point is just it's just about the general form of what you're looking at. Basically, are things like the structure, the form, and the grammar correct? Like, are they all valid sentences with a subject and a verb? And that's not to suggest, of course, that good English or nice to read English automatically means good evidence or good paper. It doesn't. But if you've got an English language journal and you're reading an English language paper that perhaps doesn't have properly formed sentences or bad spelling or, you know, things that don't feel right, it just may mean that it's not been through a thorough editing process, which would be very unusual for a high impact factor journal. So it's just something you could bear in mind.
Yeah. But I think for this one, this is more for papers, because there are some deaneries that will email you the paper like a day before, and you have to like read it inside and out. And then London and other deaneries may just give you an abstract. So obviously figures and diagrams may not be applicable for them, but there are some abstracts that will include it. But that's what I wanted to say before I handed it over to Ollie again.
No, it's absolutely right. And this applies obviously much more to papers themselves, as Aqua says, because abstracts don't have any of these additional elements in, but you may be given a paper. I, for example, in my interviews, never had an abstract or a paper to look at, but my critical appraisal skills were tested in other ways. And one of the really common things was looking at graphs, actually. And so the same, your critical thinking skills apply if you're looking at something like a table or a graph. Is this what it says it is? You know, it says a graph showing X, Y, Z. Do the axes or whatever match that? Is there a funny scale involved? Are the units of measurement appropriate? Things like that. It's just applying your general critical thinking skills to a piece of evidence. You know,
Yeah.
If you ever did GCSE history, you'll assess provenance. It's all about that. Now, detail. A good or appropriate abstract should be written. The goal of an abstract is such that either a subject expert, you know, Aqua, for example, knows a lot more about urology than I do, and so her ability to interpret an abstract to a urology paper is much more specialist than mine is. But a good abstract for a urology paper needs to be such that both Aqua and I can understand it separately and get the same basic information from it. Yeah. I say an abstract is kind of useless if you have to be a professor of urology in order to understand that paper, because that's not really an abstract, is it? That's just...
But I think what's important to raise is that your interviews will be a very high stress environment, you know? Mm-hmm. And when you're reading this abstract, you're going to have your nerves, like no matter how many you've done, like I think I did at least 20 to 30 mock interviews where I literally practiced with a mate an abstract, reading it in like 10 minutes time and then trying to like summarize it and stuff, which we'll go through in a bit. Yeah. But I think you need to absolutely read abstracts that aren't part of your comfort zone, because like obviously with me, I had urology and men's health are my areas of interest. So when I was given an obstetric paper, I absolutely had like a little meltdown because it felt like I was reading jargon, which is like, that is absolutely not acceptable. Like I need to be able to critically appraise anything and everything, right? So I think you absolutely try to write down different topics, and what they're going to test you on is something that you should know. Like there's you can pull out like a relevant guideline or a relevant rule that you will learn at medical school. Like for example, bowel cancer screening. Like everybody needs to know that at med school. Or like AAA screening, you know? Like there is something that they will directly pull out of you, or they're looking to see if you'll say that guideline. So for me, they were looking for something to do with gestational diabetes, and unfortunately, I didn't get to say it. I still, did well, but not as well as I could have because of my anxiety and how shook I was, because it was something that I wasn't 100% comfortable with. So my advice would be, make sure you read abstracts that, you might be like high and mighty in your little area, but be familiar with bits and pieces of everything.
Yeah, good advice. And then this next one, definitions. So this is a kind of a cynical element to all of this, and it's harking back a little bit to what we said earlier about titles that are written to grab attention, right? Papers are published for a reason. No one does it, well, I say maybe some people do it for fun. Most people don't do it for fun. And given that we will make medical and clinical decisions based on these papers, potentially, and often that's what people are trying to sell, or they might be trying to show that a product or a pill or something is better than another. When they're describing what they're doing during an article, you need to be sure that they have been clear with their methodology and their process. So the abstract basically needs to describe everything that they did without going into overbearing detail. And it really doesn't take much because, like I was saying, a systematic review, we all kind of know what that is and we know how it's done, or at least once you've been in the game a little bit, and saying we did a systematic review of XYZ kind of tells me everything I need to know. But when you get into more complex and niche situations, if they're, for example, comparing treatments, they have to really specifically lay out, we compared X with Y. If they said that participants were randomly selected, for example, they should be saying how do you achieve that? Because actually true randomness is extremely difficult to impossible in order to achieve. So they need to say how they managed to do that, or if they anonymized something, how they did it. If they are comparing a treatment to something else, they need to tell you what they were measuring, or indeed, if they were investigating the efficacy of something, was it being compared to a control, or are you simply just observing what happens if we give someone a tablet?
Yeah.
And just writing down what happened, essentially. And then...
Conscious of time, though, this is not as relevant, I don't think, anymore.
Yeah, it shouldn't be. It's really simple. Is it an old or a new paper? When was it published?
Yeah, and if you see like a big, we'll go through one of the papers that has changed clinical practice. But obviously now, thinking about equipoise, if something is now an established gold standard, it wouldn't be right for us to carry out a similar trial, because now we know that the gold standard has obviously proven beneficial. So just to bear in mind.
Yeah.
But basically now I'd like to expand on Pico. And essentially this is how, when you're asked in your interview to summarize a study, this is what your first one will be, what is the question that they're trying to ascertain? And then you'll go into the Pico format. And with population, you are looking at who was involved. Did they include a pediatric or an adult population? Or did they go both? Did they use a whole consensus type thing? Did they specify gender? Did they specify ethnicity? What was their sample size? And did they look at any pre-existing health conditions, or were they specific about it? And yeah, if you're wondering who they are, then that is a bias that you can raise. With intervention, you need to be able to know what was actually done. And the most common, study design that you will experience in your critical appraisal is not always, and we will go through it, I think, in our third or fourth session. There are different, in one of our interviews, we were given the N of 1 study design, whereas we were told that you'll most likely see a cohort or a case control or a randomized control trial. But, they can throw you a curveball. But with intervention, did they receive a treatment? Did they not? Or did they receive a placebo? This is the active thing that the study is testing, whatever the item of interest is. C, control, well, actually, placebo should be here more than I.
We were arguing about this earlier.
Yes, exactly. No, C is always control in my eyes. That's the comparison. The thing that the intervention is compared to, when it's and this is more applicable for, for example, an RCT, where an RCT is basically the gold standard study design when you're trying to compare or assess a new intervention, because you're trying to compare it to something that's existing in practice or placebo. And then, outcome. What's the main outcome? And here is a nice segue into me saying that there are some conditions that unfortunately are hard to come up with a strict outcome. So they can use composite or surrogate outcomes. And those are some things that we will cover in a later session. But as of now, just write them down so you can look them up, because that's how you can sound really, really clever. But most of these will be relevant for clinical practice. And when it comes to reading an abstract, you really need to think critically and think, will these outcomes change your practice? And are the outcomes measured, like whatever is being examined in the abstract, does it match the claims that could be made in the title or the discussion or the results? But yeah, now we will go briefly into how to discuss a paper, essentially basically how to sound as smart as long as you need to. So, as I said at the beginning, you need to be able to summarize the Pico. So you're going to start off with trying to be like, this is a study looking at XYZ, XYZ that was published most likely in this journal, because again, you should be able to make some inferences into which journal it is by going through and reading BMJ, Lancet, JAMA, blah, 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 blah. You should be able to like kind of guess which journal it is. Then you go into your P, it's looking at XYZ patients from XYZ demographic, if they go into, that specific detail. It compared whatever the intervention was to whatever the control was. Primary outcomes, secondary outcomes. Then you're going to try to summarize the major findings, and you are just thinking back to when you had to do your verbal reasoning in your UKCAT if you took the UKCAT exam. And now I'd like to talk a little bit about validity, because these are like hot buzzwords that you need to go back and read up on. And for the purposes of today, internal validity is looking at the truth of, within the study itself. How sure can we be with this specific research or this specific paper? And, how strong can we make the causation with the methodology to the results and to its claims? With external validity, truth in reality, which sounds very biblical, I guess. How generalizable is this in the real world? So, the way that I split up internal validity and the way that I think I took really, really great interest in looking at, I think it was like an imperial group, and I think, what was it called? There's a great YouTube channel, which I will copy and paste a link to later on. But the way that they split up internal validity is something that I have taken, for my critical appraisal way now. The first one I'm going to be looking at is recruitment. And what that is how did this specific study recruit patients? Was it consecutively? And the scope means more like, was it international? Was it multi-center? Was it in the country? And how many centers did it include? With the title itself, or within the first few lines of the abstract, you should be able to gather the scope and how big of a study it is. And in terms of allocation, how did they allocate the groups? Some really, really good abstracts will be like the patients were allocated in a 1-to-1 group, which means that if they had, for example, 60 patients, a 1-to-1 ratio is 30-to-30. And not only that, but they will go into depth on how did they randomize, how did they use cluster randomization, did they use block randomization? And that is how I segue my mind into allocation. Basically, how did they sort these groups out? Again, I'm most likely talking about either a cohort or an RCT, because that is what you're most likely going to get. Do they talk about attrition? Do they talk about dropout rates? That's pretty much it. Or did they talk about any intention to treat or per protocol? When it comes to blinding, was it single? Was it double? Was it triple? In the abstract, they should describe what level it was. And number 5, statistics. Usually, again, unfortunately, in the abstract, they won't really go into depth with the sample size, like how did they actually power, and was the sample size actually enough to adequately power the study? And what that means was these amazing statisticians will sit down in a group and really think about the accurate number needed to draw a conclusion to the question that they're trying to answer. And for example, if they were looking at non-inferiority trial to answer is X equivalent or non-inferior to Y. So we need 500 patients. But for example, they recruited 400, then that technically could mean that it's an underpowered study, unfortunately. But again, they probably might not write that in the abstract. So in your critical appraisal summary, what you would say is, I acknowledge that like the sample size is 400 and it was split so that 200 patients were in group Y and 200 patients were in group X. I would want to read the full paper to see if it met the sample size calculation, to see if it was adequately powered. That's just, this is just jargon you need to memorize so you sound really good on the day itself. And PPI, Ollie and I briefly talked about it when we were talking about is it an accurate representation? Like if Ollie was doing like a big study on assessing female perceptions, did they have input from patients and the public? This is not really commonly talked about, but again, this is something that you can really, really stand out with if you just want to say that you want to look for at the full paper to see if they really, I guess, took consideration into PPI. Sorry, don't know why it's doing that. Yeah, and then there are some little extras that we will expand on in another session, but there's external validity. And what external validity was, what I said already, was how generalizable a study is. With funding, when it's usually mentioned, for example, big drug studies will say it's usually funded by either Pfizer or a big drug company. And what you have to say then is during an abstract, you note that it was funded by XYZ. So you'd like to read the full paper to know if they contributed to the study design. Because if they did, then that could lead to a bias. And equipoise. Is the equipoise to give a group an intervention that you may know might not be the best anymore? Then unfortunately that trial might not have equipoise. And you really need to think about the 4 pillars of ethics, which you would have gone through if, when you were preparing for medical school. And we will go through this, I think, in either session 3 or session 4, the 4 pillars. And this is not something that you will commonly see in abstracts, but this is something that I think you might be able to see in a full paper. And that's a data and safety monitoring board. And essentially what they dictate is that this board basically has the power to stop a trial if too many side effects or too many adverse events are happening, essentially. And they can perform like interim analyses. And yeah, we'll cover these in depth in our sessions. And I'm trying to be mindful of time, which is why I'm trying to get through as much as possible as I can. But I think sorry, I just realized that there are so many questions.
It's all right. We can. I've been trying to keep up. We can go back to them because we're doing great for time. We're going to finish.
Okay, good. Right. So I'd like to just now go back to the crowd. Have they used meta-analyses as well? Yes, they have. I know of not last year they didn't. I don't think they used a meta-analysis. But I know that they have, definitely. I'm just coming back to questions now. But I guess this is an abstract on the screen right now. Can somebody tell me which journal this is from? Just hazard a guess, anybody? No, it's okay. It's great, Amanda. And sorry for not paying attention. Yeah, okay, so Amanda's given an answer. Anybody else? Yes, Payam. Any more? Any more takers? Yeah, it is. It is New England. Very characteristic of them. And as I said, see, it's bracket funded by blah, 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 bracket. So during the Pico, if we go into that, can somebody tell me what the P is for this abstract? Not a trick question. But do you want any help? Well, I'll just go. So P here is there were 46,500 participants, and they were 50 to 80 years of age. Yeah, exactly. Good. And I would mention how many participants they actually included.
So I'm going to challenge you, Aqua, if I may. Only because what we're doing here, guys, obviously is showing you an actual abstract as one exists in the wild. And so it might at any stage, I think, be reasonable for them to fire a question at you. So I'm going to challenge Aqua here, which is, why is this age group relevant for what the study is testing?
Because it's fecal occult blood testing. Yeah, this is the patient population that is most at risk.
Yeah, exactly. So you wouldn't do this in
kids.
Like you wouldn't do this, in kids or 15-year-olds, would you?
Exactly. Yeah. Good job. And then, can somebody tell me what is the intervention? This is a good one because this isn't really, I guess, somebody was given drug X and they were compared to a placebo. Close, Amanda. Again, close, Oluwa, Toby, if that's how you pronounce your name. It's actually annual or biannual. I'm not sure how you pronounce that word, screening. But that is the intervention. So then what would the control or comparison group be? Yeah, exactly. Usual care. That's the control. And then what about O? O is kind of tricky in this one. And I had to kind of read a bit more into this abstract to kind of get what O was. So, not reduction in mortality, just mortality itself, right? That's what they were looking at for the outcome. Causes of death, essentially. And that's how I kind of realized. Because I was like, okay, they're looking at colorectal related, exactly, mortality. And in terms of findings, can somebody tell me a key finding that you've read from this abstract? It's not a trick. So, it doesn't influence all-cause mortality, but what can it influence? Gayatri kind of alluded to it. Amanda? Essentially, what it's found was screening did help with colorectal cancer-related mortality, but not so much for all-cause mortality. Does that make sense? So it's basically segued, it separated mortality into two.
Yeah.
Yeah.
And it's what you would expect, isn't it? Like if I go out, if I walked outside of my building now and I got struck by lightning, it wouldn't be affected whether or not I had my bowel screened. One would hope.
Are you sure?
Yeah,
sure?
I can't tell that. I've not done a study, but
yeah.
it's a big difference in that sense between all cause and specifically
bowel related.
Yeah, looking at the thing.
So now going into like the extras, we know that there was some randomization, but I'd like to read the full paper to know how they actually randomized the patient groups. And as I said before, we know that there's 46.5 thousand patients. And something that is really, really nice is that 46,000 patients is a huge sample size. So one could assume that it might be adequately powered, but you'd want to read the full paper to see if they did, what was the sample size calculation? What was the sample size that they needed for the study? And another really, really good thing that I saw was that they had a 30-year. No, not necessarily, but it makes you look good. And nowadays, more and more, like old papers won't go into depth in the abstract on how they randomize patients. But as the quality of evidence gets higher and higher and higher, and as we scrutinize and critically appraise papers more and more, you might be able to see, oh, they were cluster randomized, oh, they were block randomized. You don't need to know specific definitions, but you need to be able to pick them up, Amanda. If that answers your question. But I would think that 30 years of follow-up is a decent amount of time, to be honest. That's a really, really good follow-up time. And I think crucially here, what's important is if, for example, again, I'm just bringing my area of like what I want to do, prostate cancer. If we were looking at prostate cancer outcomes, if we were only looking at outcomes for, a year or two, and we were trying to see if it was related to mortality, 1 to 2 years might not really be appropriate because prostate cancer, as we know, if you've got like a low grade cancer, then they're not really aggressive. So that wouldn't be appropriate if it was just for 2 years. Whereas I think 30 years for colorectal, that's really, really good. But that's pretty much how I've summarized the paper.
Yeah, so really well done, guys, in the comments. If especially if this is the first time that you're trying to do something like this in a room full of eager people, just by virtue of being here, you are all extremely switched on. So it's a lot of pressure. We're going to do the same thing again. Mine's not presented as nicely, but this is one of my favorite papers to show people when we're thinking about critical appraisal. So I'm going to give you less lead in this time, and we're going to do literally the same thing again, and then we'll just have a few minutes for questions at the end. But rapid fire, I would like everyone or whoever's willing to come forward to do any element of Pico that they like. So the P, the I, the C, or the O. Just choose one of them and put that in the chat. Or if there is something interesting that you note about the paper or something that you would raise as a discussion point with your examiner, put that in. So the idea is that everyone who's willing to chat can choose one thing. So any element of Pico, or it can be any discussion point just based on this abstract that you would raise as a thought. So it can be any of the things that either I said when we were going through those key questions at the beginning, or anything from Aqua's session. So you've got a really wide scope here of things that will be valid.
Yeah, literally, say anything. Critically appraise this abstract.
Pun very much not intended.
Somebody give me a P. What's the patient population?
Give me a P.
Yeah. Do you know what that means, Amanda? Yeah, Gloria, exactly.
It's well done.
That's a perfect P. Yeah, exactly. Very good point.
Yeah.
Yeah. So you've basically done both I and C there, Amanda. Yeah, exactly.
Oh, yeah.
Yeah.
We're getting there. We're filling them all out, so we just need
Yeah.
O.
Somebody tell us O.
Oh, this is great. I didn't expect that to work.
Yeah, it works. I think they just have to read it.
Yeah. It's a nice abstract. I think it's
Yeah, very, very, very fair. Yeah. And they probably may have. So, Oluwatobi, you're saying that when you're reading the abstract. So what do you have to say at the end of your sentence? When it comes to every discussion point with the abstract? You need to read the full paper, because if it's a good journal, they probably did look into this.
RTFP.
Yes. Yeah.
Read the full paper.
Exactly. No, yeah, exactly, guys. Well done. And I think I'm going to ask you the same question as they did with the last abstract. Which journal is this in again? Not a trick. Yeah. It has the same, like, funded by blah, blah, blah in the brackets. Yeah.
Yeah, exactly. Again, New England Journal paper. And if you think about, the scale of what this study was trying to achieve, because what they're basically saying is apixaban, which was then at the time when this paper was published, a NOAC, a novel oral anticoagulant. What they're basically saying is, we have shown in this huge number of patients in this international trial that apixaban is essentially superior to warfarin. Therefore, thousands and millions of patients around the world need to start being treated with DOACs instead of warfarin. Like, think about how huge a claim that is. Like, just in terms of, you've knocked the bottom out of the pharmaceutical industry for any company that makes warfarin. The stock price of any company that makes any form of apixaban,
it's probably sky high now.
Yeah. This is the impact that this has, not just on patient care, but on the pharmaceutical industry, the stock market, like, huge.
Yeah.
But
somebody, I think Amanda, raised non-inferiority. Can somebody tell me the difference between non-inferiority and superiority trial study designs? And if you don't know, this is something that you should look up. Equivalence versus non-inferiority versus superiority. Because those are...
Or what you think it might mean.
Yeah, true. Yeah, exactly. And I think, correct me if I'm wrong, but this was designed to test for non-inferiority, but what it actually found was that apixaban was actually superior. Not only was it non-inferior, which means, yeah, it's the same clinical benefit, it actually ended up trumping warfarin. So with non-inferiority, you set a little, amount that it needs to meet to be claimed as non-inferior. And then if it goes above and beyond a certain, number, then you can claim superiority.
But Aqua, who's funding the paper that found
Okay,
this?
fine. Drug companies, but this was a massive study. So naturally you would...
Yeah, I'm just raising it as a discussion
of
point.
Course.
Like you were...
Yeah, they are drug companies, but what do we have to say when it comes to critically appraising? You need to know their involvement. Did they help with study design? You would hope not.
Yeah. Oh God, what a disaster.
Exactly, yes. Oh, actually, and another really, really good point here is that, if you guys can notice, Aristotle clinicaltrials.gov number, NCT. Does anybody know why that's important here? That they've given their clinical trials registration number. extra brownie points, if you can tell me why. Yeah, transparency, good. There are some key words that I want to hear from someone. They're like Latin words, and I don't know how you pronounce them. Yeah, ethical approval, yeah, keep going. And this is something that will make you sound really, 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 really smart. No takers? No? Okay, fine. So, a priori. Essentially, what that means is that when you register your trial on clinicaltrials.gov or WHO, for example, any place that you can store your protocol or what you set out to do, that means that you're less likely to change your outcomes, which means that there's less bias because everything was set a priori, which means that things that have already happened beforehand. If, for example, there are some sketch studies out there, like really, really old school, where, for example, they attempted to do a non-inferiority trial, but then also they attempted to do a superiority trial, so they needed to meet like a higher number, but then unfortunately, because patients weren't recruited well, they've now changed the outcome to non-inferiority or something, or they've changed like, actually a group is dying more. Maybe we shouldn't have mortality. Maybe we should look at side effects as our outcome. That's not good because that's changing the study, isn't it? So when you see a clinicaltrials.gov number, you know that everything was set prior. So they have like a set protocol to follow, essentially. So when it comes to critically appraising it, you'll be like, I noticed that the Aristotle trial had an NCT number, which means that outcomes and the protocol was set a priori. That's all you say. Boom, another keyword. Set in stone.
Well, I think, does that bring us to questions then?
Yeah, I think so. Yeah. Do you guys have any questions at all? Because one of our comments from the previous lecture, we went on and on and on, and I think we hit like 9, and somebody said this should strictly just stick to an hour, so we wanted to just be mindful of that and, your time.
Yeah.
Yes, they will. But we have a dedicated session to that.
Yeah.
Do you have any particular facts? Okay, so we've seen New England a couple of times. So let's just say onset to the, let's see. Onset BMJ, what else? Oh, another good
JAMA, maybe?
Yeah, JAMA as well. Because they will most likely just copy and paste. They unfortunately will not give you a screenshot from the journal itself.
The logo in the corner.
Yeah, the logo is like, it's from this. So I don't think Lancet have the funding like that, the way that NEJM does it. I think Lancet have a separate little section called funding.
Yeah, I think like a declaration thing.
Yeah, it literally just says like funding. And then BMJ, you're not being lazy. I think genuinely you need to look. They will only pretty much give you the abstract, or they'll give you like if, for example, they have like a funding statement, they'll give you that. And if they have given you a bit more than the abstract, they are most likely wanting you to comment on it. Otherwise, they wouldn't have given it to you, Amanda.
Yeah. Again, trying to come back to what some people have said, although like these skills are important and they're important for all academics, especially for you guys that will be going into your specialized foundation program. Now it's you that's going to be responsible for a lot of these things, regardless of whether you are asked to critically appraise an abstract in your interview or not. You will need the skills anyway, so they're worth learning. especially if you start going to journal clubs and things, which is a great thing to do. And B, you, even though you may not be given an abstract, you can be asked about any of the things that we've talked about, because they are all important skills for a young academic. Or, you know, you could even be asked to design something. Like, how would you design a study that could capture X, Y, Z?
Yeah, like they'll give you something, they'll give you a trial, and for example, we'll go into depth on our study design session, but they might ask you, do you think that this study design is appropriate for answering this question? And that's when you really need to become familiar with, why have they asked me that?
Yeah.
But Oliver Toby, I don't know if that's how you say your name. So for London, I think we got 15 minutes to read it. It was just shown on the screen, and then you only have 10 minutes. And I think like some interviewers will be like, okay, summarize the paper, and then won't give you any cue. You just keep talking for 10 whole minutes, and they don't prompt you, they don't stop you. Whereas some examiners will be nice and they'll ask you questions along the way. Or some examiners may grill you. Like, there's a standardized mark scheme, but there's no, I guess, standardized way of asking questions, if that makes sense.
Yeah. It's usually all about probing your knowledge, isn't it?
Yeah, exactly. And I think generally they want you to do well, and they will try to suck up or ask you the right questions so that you can say the buzzwords or the keywords that, you know, we went through today.
Yeah.
And I know some deaneries will email you out the paper one day beforehand. So that naturally means you won't sleep. You'll read it inside out, and you will probably Google it. Yeah, exactly.
We'll give it a couple more minutes, guys, and then in response to our feedback from last time, we'll can the session at 25 to.
Yeah.
But just as an in general, as we move towards the close, thank you all for coming. It's really lovely that you know, so many of you are giving up your time, because that's what this is, to basically try and come and be better at something. And that's very meaningful.
Yeah. Do you have any more questions, guys?
And as ever, there's a link just gone out in the Medal chat, but please do fill out the feedback form if you have the time and or inclination to do so, because it really does help us. It's basically the mechanism that allows us to do this for free, as well as Medal obviously being the amazing
Great platform that it is.
Yeah. And equally, when it's you guys that are on the other side of this in a year, in 2 years, we hope that you are also doing these webinars to help the next generation through, because it's a difficult process.
Yeah. But I think there aren't any other questions.
No? Cool. Well, that's it. 25 to. Thank you all for coming.
No problem. Thank you so much, and thank you for the interaction, guys, because you're going to be doing this. And I know it's super, super, super early on, and you might not be thinking about, you know, interviews just yet, but it's always better to get started early. No problem. And we will go more into depth in, we were aware of the time constraints, and we really wanted to go through the examples first. And we will go more into depth with the different terms and the study designs, because I think that's where the nitty gritty, you know, the hot topics are.